Sadly, today I do not have my cameraman, so there's a lot of editing on my part. So the first thing we're going to talk about is cardiac tamponade. What is cardiac tamponade? That is when the pericardial sac fills with fluid. You got me? It's creating pressure around the heart, so we're going to see a dramatic decrease in cardiac output, and we're going to see an increase in pericardial pressure. Here, for cardiac tamponade, I was told specifically to go over these signs and symptoms. So, with cardiac tamponade, the heart has pressure around it, so initially we are going to see a decrease in O2 saturation or hypoxemia, a decreased level of consciousness, which could be manifested by fatigue, confusion, dizziness, also called syncope or syncope, and shortness of breath. Now, when I said the first thing, I didn't mean that, but that's what's going to happen. As you can tell, I've probably got something that's going on. I'm feeling a little confused. I'm tired, but we're going to push through. The first sign and symptom of decreased cardiac output is tachycardia, or a heart rate over 100 beats per minute. Another thing we're going to see is tachypnea or tachypnea with clear lung sounds for cardiac tamponade. Don't get confused. This is a cardiac problem, not a respiratory problem. We're going to see chest pain because it's a cardiac problem. We're going to see decreased blood pressure, probably anxiety. The ECG for cardiac tamponade is going to show QRSs that are short and uneven. So it's going to be like, well, bam, right? One's kind of tall, and then you have this other one, right? We're just going to do a bad one here, and it only goes that tall. You got me? So this is related to the compression of the heart. So you have this taller peak wave of trying to overcome it, and the shorter peak wave of it not overcoming it. Now, as we said earlier, we're going to have clear heart sounds, but apparently clear lung sounds. No, clear lung sounds, but apparently clear heart sounds. Not sure about that one. Weak and thready pulses we will see with the patient with cardiac tamponade. Causes of cardiac tamponade can be related to trauma. It could be in a car accident. It could have some type of weird heart damage from blunt force injury, maybe penetrating. I'm not sure though. It could be caused by surgery, a myocardial infarction, or diseases. Now, the diagnostic tools used to diagnose cardiac tamponade, we're going to check out the chest x-ray, and we're going to see widening or enlarging of the pericardial sac because it's filling with fluid. Echocardiogram, that is going to show the fluid in the sac. And the ECG, as we said earlier, is going to be short and tall R rate. So PQRS. It's that R1 in the middle. We're going to see tachycardia, as we said earlier, ST elevations, compressed pulse rate, decrease in cardiac output, increase in sinus venous pressure, and CVP is normally 2 to 6, so we're going to see decreased cardiac output and a CVP over 6. Treatment for cardiac tamponade is pericardiocentesis. Now, when we have this pericardiocentesis done, we need to make sure we have a cardiac monitor on them. Now, this catheter is going to be attached to a drainage system. So it's just like doing drainage for ascites or a chest tube. We're draining the fluid from one space into our collection tube. So the same way we check for kinks and slow drainage in those other things, we check for kinks and slow drainage in this thing. According to my PowerPoint, this patient with cardiac tamponade may need digoxin. So, we've covered the signs and symptoms of cardiac tamponade, which we were told we need to know. So now we're going to go into the Saunders interventions because we take it up a notch here, if you know what I'm saying. We know anything and everything we can about this thing. So, Saunders interventions for cardiac tamponade. The patient is placed in the critical care unit for cardiac monitoring. So where would the nurse anticipate a patient with cardiac tamponade be transferred to? the CCU for cardiac monitoring. With decreased cardiac output, we're going to manage this with IV fluids. We're going to have to prepare this patient for a chest x-ray, an echocardiogram, pericardial centesis. And that pericardial centesis, we need to monitor for reoccurrence after. So they have that pericardiocentesis, but they still have cardiac tamponade. They still got fluid building up. So if the patient experiences recurrent cardiac tamponade, reoccurrent effusions, or adhesions from chronic pericarditis, we may do a pericardial window or a pericardioectomy. May be performed, yeah. So these two things are kind of like shunts, or they're just taking out part of the heart that's broken. And that is the basic things you need to know for cardiac tamponade. Now we're going over rheumatic heart disease. Do not let this be your only source of information for this process, because I'm kind of confused on what it is. I tried to get help on what it is, and I don't have time. So I just tried to figure it out for myself, and here's what I got. Rheumatic fever. I know a lot about that, because that is easy to find information on. But rheumatic fever is an abnormal immune reaction to GABS, in other words, strep infection. And we see widespread inflammation throughout the body. So, rheumatic heart disease, it will lead to long-term cardiac damage. Now, this results from partially or untreated strep infection, which I think is the primary concern here. Labs, we're going to see a positive throat culture for GABS or strep. We're going to see a positive ASO titer, an elevated ESR, and an elevated CRP. The Jones criteria, we see chorea, carditis, cardiomyopathy, arrhythmias, chronic heart failure, I don't know, polyarthritis, and that is an inflammation or rash that can be in the arm or the lip. Next thing we're talking about is treatment for rheumatic heart fever. Long-term penicillin administration and bed rest. Now, the signs and symptoms of rheumatic heart fever are sore throat or pain when swallowing, and based off of that. Next type, part 2, if they're suspected of streptococcal feveritis, if we're suspected of streptococcal, I spelled that wrong, feveritis, we do a rapid strep test. Okay, so that's just the jab. So if we think they have a strep infection, we do a rapid strep test or a throat culture. And penicillin and amoxicillin is usually prescribed. Now, rheumatic endocarditis is what we're supposed to really, I think that's what I'm actually supposed to be going over. I have no clue really. But rheumatic endocarditis is an acute inflammation of the heart, and it's caused by untreated strep, and it leads to vegetation and leaflets on the heart valves. It's going to have scarring. Now, for diagnosis of this, we need to have 2 separate blood cultures that are positive. And I think it has to be at least a couple hours apart. And we're going to see regurgitation on an echocardiogram. And all this is done before we administer antibiotics. So we need these blood cultures. I think we need to see this echocardiogram, but definitely get the blood cultures before antibiotics are administered. So the signs and symptoms of rheumatic endocarditis, rheumatic fever, I don't really know. Just know this: malaise, anorexia, weight loss, and joint pain. That's the same signs and symptoms you see with the flu. But here's another thing we have. We have an increased WBC over 10,000. We can be anemic. We can have a positive rheumatoid factor, an elevated ESR, and an elevated CRP. An echocardiogram may be done, and we'll see masses on the valves. And I'm fairly certain that's to determine the difference whether or not it is rheumatic heart disease or rheumatic fever. Okay, what are we looking at now? One thing that I was told I definitely need to go over: coronary artery bypass graft. Now, all I really think I need to know is the cardiac rehab, the complications, stuff like that, but you know we go hard here. So the first thing is the coronary arteries are bypassed because guess what? They ain't working right, or they're too slow. It's like there's a traffic jam and Google Maps redirects. So basically, this is performed when the patient does not respond to management. or if the artery is occluded. Chronic stable angina resistant to treatments is an indication for coronary artery bypass graft. Failure of PCI or stuff that's freaking resistant to PCIs, that's an indication for coronary artery bypass graft. A left main artery occlusion over 50% is an indication for a coronary artery bypass graft. We just forget the colors today. And we're going to have an increased mortality rate in people with left ventricular dysfunction. Why did I write that out? People that are older, emergency situations can have an increased risk of mortality, and female gender. Sorry, ladies, cabbage is not as good for you as it is for men. I apologize. But you're going to remember on the test for taking the same test I'm taking. So let's see here what we got next. We're going to have to do a lot of cutting here and a lot of cropping, and it's going to be so annoying. I wish Kayla was here to do the camera for me. So pre-operation for a coronary artery bypass graft, we need to instruct post-op pain is expected. So post-op pain, we got to give them pain meds, so on and so forth. We need to instruct how to splint the chest incision. We need to instruct coughing and deep breathing post-operation. And we need to go ahead and let them know how they use the incentive spirometer. You know how to use an incentive spirometer? You suck, you don't blow. Okay? I got that wrong for so long. It's not even funny. I think I missed that on 2 tests. And nobody ever explained it to me. And I never bothered to look it up. I just thought you blew into it. And then one day at clinicals, the nurse saw me telling the patient that they needed to blow into their incentive spirometer. And she's like, what the heck? Who told you that? So, yeah, now you won't have my embarrassment. Okay, so meds discontinued prior. Let me make sure that I'm low enough down here. Yeah, I got plenty of room. So we are going to discontinue diuretics 2 days before cabbage. We are going to stop digoxin 12 hours before cabbage. So diuretics. So a good way to remember this is diuretics. It has 4 syllables. Divide that by 2 and you got 2. So 2 days. There's 2 numbers, so add 1, and then it's 2 to 3 days actually. So that's how you're going to remember it. It doesn't make sense, but I'm telling you, this kind of stuff works for me, so it might work for you, which is also me listening to this. Digoxin 12 hours, that's just how long digoxin lasts in the body. And anticoagulants 2 weeks. So if you are anticoagulating, you need a 2-week vacation before you can go coronary artery bypass grafting. I wish that rhymed better. So post-opera cabbage, we need to avoid lifting, so don't go to the gym. We need to protect that incision from infection, so no baths or soaking the wound. But we can give a shower. So patient can't be in the bathtub, they can be in the shower. We need to monitor for redness, warmth, swelling, draining. That is indicative of infection. And if it's at the incision site, or if they have any of these things, we need to call a healthcare provider. That is the priority for an infection in these patients. Let's see what we got next. We are talking about the post-op care for cabbage. We need to manage fluid and electrolyte imbalances. We need to check the chest tubes, and if it's over 100 milliliters an hour, we need to call that HCP. We're probably going to have them on fluid restriction after the cabbage because we got risk for fluid volume overload, which can lead to right-sided heart failure. I think. Double check me on that. Let me know if I'm wrong. We need to monitor for, what is this? What is this? We can go back to red because guess what? It's cardiac tampinaide or cardiac tamponade. And if we are having a coronary artery bypass graft done and we are in the post-operative period for this treatment and we have signs and symptoms of a cardiac tamponade, we're going to see sudden cessation of draining. Did you see how I transitioned? I adjusted the camera and then I came back and kept on doing what I was doing. That was so seamless. I shouldn't have said anything about it. JVD with clear lung sounds. Equalization of RA, right? RA and pulse pressure. I don't know what that means. We're going to see pulsus paradoxus, which is a big thing. I don't even think I mentioned that over there. Now, we're going to see an increase in temp, an increase in WBCs, and if that's for 3 days, we got infection. So we need to go back to blue because we're not talking about cardiac tamponade anymore. So let's go back and talk about cardiac tamponade for one more second real quick. With cardiac tamponade, we have a sudden cessation of drainage, JVD with clear lung sounds, equalization of right atrium and pulse pressure, and pulsus paradoxus. So the next thing we are talking about is infection. So with infection, if we see an increased temperature or an increase in WBCs for more than 3 days, that means we got an infection. So with these patients, we need to educate them to gradually resume their activity and discontinue that activity if the blood pressure drops more than 10 to 20 millimeters of mercury or whatever it is, or if the pulse increases more than 10 beats per minute. Now, complications of coronary artery bypass graft. Now, this is the kind of stuff I like to get into because this is the stuff I think is actually going to be on the test. Because guess what? All she said about the complications of coronary artery bypass graft were. This is my favorite thing ever. If you see hypertension, call the healthcare provider. That's all she said, and I love it. Now, with cardiac rehab, this is 6 to 12 weeks post-op. We have to do a lot of education for these patients. And this is what the professor told me to focus on this part of the exam. For coronary artery bypass graft, she said, focus on education post-op. And that's all this is after here. So we're going to do a diet, and it's going to be a decrease of sodium. We're going to decrease sodium and decrease fat. No canned foods, no fatty foods. We're going to stop smoking. So remember, diet, decrease sodium, decrease fat, stop smoking. We're going to do weight management. So diet, we're going to decrease sodium, decrease fat. We're going to stop smoking, and we're going to do weight management. We're going to do lipid control, so we're going to have a diet where we decrease sodium, decrease fat, we're going to stop smoking, have weight management and lipid control. The medications, we're going to have medications too. Now, they do not have an exercise tolerance. They can't walk up a set of stairs without being short of breath, so they need to build that strength back up. They can't just go run a marathon after a coronary artery bypass graft. They're going to be out of breath. That's the biggest thing with that, is they're going to be out of breath afterwards. So now we're going into home teaching post-CV surgery, and this is a coronary vascular surgery. This is a coronary artery surgery up here, but I think this could be important stuff right here. And I need to do it in a different color. What color will I do it in? I've been switching around a bunch. So let's do red. And then for SARS and ARDS, I'll start over with something. So home teaching post-CV surgery. And I think that this pretty much applies here too. Now, I think this was from Saunders. 6 to 12 weeks may take years. Ambulate because of pain and soreness. And if we do this, we'll have if we ambulate despite the soreness and pain, we'll have a decreased risk for clots and atelectasis. Sore throat related to intubating. So we need to do throat care, which is gargle, warm salt water. For the chest incision, no pushing, no pulling, no lifting over 10 pounds for 6 to 8 weeks, no driving because of airbags, and we need to make sure we monitor for that leg incision care. We're going to do compression stockings and elevate. And when do we call the doctor with that leg incision? We call them when we have signs and symptoms of infection. And the big key point here is increased leg circumference. I got it right down to the bare bone, the bottom wire with that one. Yes, sir. Okay, so we got SARS, we got ARDS, we got fair amounts of questions. And check it out. What we got? SARS and ARDS, the coronavirus. We need a different color. Let's go blue, respiratory. Coronavirus is spread via contact with respiratory secretions or infected person. Now, I put all the crap on here that I missed in the last exam, so if you screwed up on the last exam with this, this is gold, okay? So coronavirus spread via contact with respiratory secretions or infected persons. We do airborne, contact, and droplet precautions. For coronavirus, we have airborne, contact, droplet. So, coronavirus, ACDC. So think about it. Airborne, contact, droplet, coronavirus, ACDC. If you can name an ACDC song in the comments below that's your favorite, I would appreciate it. Let's see, anything, ACDC. See me fly into the sunset on your color TV screen. It interferes with gas exchange. if you know what I mean. E. coli. Now, we're going to have, that was actually kind of, that might be kind of helpful. That was kind of dumb, but it might be kind of good. So let's go into the signs and symptoms of COVID. We got sleuthing. I don't even know what that means. So check that out. Shortness of breath, dyspnea, hypoxemia, and is mild at first but progresses in severity, and it results in respiratory failure. So it's kind of like dating girls at ABAC. I hate to go there, but I gotta remember this stuff. So mild at first, but then it ends in respiratory failure because you're going to die at some point with that kind of relationship. So the signs and symptoms of COVID, remember, sleuthing, shortness of breath, dyspnea, hypoxemia. Now, the incubation for coronavirus is 7 to 10 days, and initially we see a high fever over 100.4 and chills, bro. Just like dating an ABAC girl, bro. I mean, this is all for memorization, just so you know I'm not actually crazy, but ABAC girls, bro, they hot. They're over 104 degrees, and they give you the chills, but the problem is they give you respiratory failure. And that relationship will progress to respiratory failure, ARDS, and multiple organ death syndrome, or MODS. So I don't even remember the acronym for MODS. Let's go down to the next thing. Am I even on the right thing? I am on the right thing. So, nursing actions for COVID. We need to make sure that we do prompt identification. Remember, ACDC. We have airway, airborne contact droplet COVID. So, ACDC's coming to this show. You see them. You already know who they are. It's prompt identification. And we're going to notify the healthcare department because ACDC is sick, yo. That's stupid. I got this wrong because I was like, why are we talking about tuberculosis? We do that for tuberculosis. I don't know if we do that with COVID. Turns out you do it for COVID. Now, infection control measures for COVID, which I think is of the utmost importance for what we're currently going over. We need to worry immediately. We need to do standard contact and airborne precaution. This includes goggles, gowns, and N95s. Goggles, gown, and N95 going to the ACD concert tonight. So think about it. Michael Jackson, bro. Michael Jackson. He got the gloves. I think he wears those big sunglasses too, or he used to wear the big sunglasses too. So he's got the gloves, the goggles, and if he was still around today, he'd have that N95 mask on, if you know what I'm saying. ACDC and Michael Jackson. I'm too tired to be doing this. I hope nobody watches this. Now, if they're at home, they need to stay there until 10 days after the fever is gone and signs and symptoms are absent or minimal. Let's go down into the next thing we got going for us. What do we have? DX, so diagnosis for COVID. We're going to do the serology test, also known as the ELISA or immunofluorescence. ELISA, what is that for? I think I know what that's for. That rhymes with something that sounds like man-A-B, HIV. That's what you use the ELISA test for. So we're going to check out the reverse transcriptase. That is the fast version of this, from my understanding. CXR may show infiltrates. The SpO2 is going to be hypoxemic. Now the CBC, this is where it gets tricky. We're going to see decreased lymphocytes, leukemia, and with that we're going to worry about infection. Thrombocytopenia, decreased clotting. With that we got to worry about bleeding. With CPK we're going to have an increase in ALT and an increase in ALT. Made it to the end of COVID, boys. Let's see. Now for sputum specimens, we're going to do gram stains and culture to rule out pneumonia. So if we don't know if they have COVID or pneumonia, we're going to do gram stains and cultures to figure out what the heck it is. Now these blood cultures are going to identify the bacteremia. Now meds, none are proven effective according to the PowerPoint. Antibiotics, if it's unclear between COVID and pneumonia, definitely give antibiotics if they have pneumonia. Now, interventions for COVID supportive, we're going to do O2. We may intubate or we may mechanically ventilate the if you know what I'm saying, bro. And that's COVID for you, right? We got ARDS. It's like SARS, but it's an ARD. An ARD, think hard alveoli, because they party too hard. Those capillaries are inflamed and fluid filled. We're going to have no O2 coming in and no O2 coming out. What's going on? We got that impaired gas exchange. Priority nursing, diagnosis be that, and ventilation. We're probably going to put them on a vent. Now, the biggest thing with this is, with the patho, you just need to know that the alveoli become fluid filled and they become stiff and rigid and hard. Causes of ARDS can come from inflammation. We forgot to change the color again. Inflammation, sepsis, pneumonia, toxin inhalation, or acute pancreatitis. Now, the key with that acute pancreatitis, according to simple nursing, is that you have an increased risk for having ARDS with acute pancreatitis. And that shows up on the NCLEX and something. That's the first time I've ever seen it. So signs and symptoms. The key thing with ARDS is refractory hypoxemia. And that is decreased O2 despite administration of O2. So we're giving them O2 via nasal cannula, but their O2 stuff's just not coming up. Now we got the suprasternal retractions. I put Supra in there for a reason. You ever hop into a Supra? You ever drive a Supra? When you step on the gas, your lungs cave in and you can't breathe. So suprasternal retraction, that's what that means. Your lungs cave in and you can't breathe. I'm going to double check on this thing, make sure we still good. We still Gucci. Now we're going to have tachycardia, diaphoresis, decreased level of consciousness, cyanosis, and pallor. That's all of your signs and symptoms, mostly related to decreased oxygenation. My camera's getting hot. We going straight through this, bro. No breaks. Labs. PaO2 is low, below 80. So on the question, you need to look for the one that has the lowest O2. Now, we're going to have a high CO2, over 45. Look for the highest CO2 on that answer. Remember, no O2 in, no CO2 out. Chest x-ray may show diffuse and extensive bilateral, interstitial, and alveolar infiltrates without heart failure. So interventions for a patient with ARDS. Vent on PEEP and endotracheal tube. First thing, second or is vent on PEEP. My PowerPoint confirmed. It concurred with that intervention, but it also said endotracheal intubation. So we need to rotate this client. I think it's from supine to prone position to help out with that loosening secretions and stuff. General respiratory stress. So just if they have respiratory distress, you need to call the rapid response team. There's a certain order you need to do it in. First, high Fowler's position. Do not call the healthcare provider first. Increase that head of the bed. Now, second, we're going to suction. Third, we're going to do O2 administration. Fourth, we're going to check those lung sounds. And then fifth, we're going to yell for help because we are strong, independent nurses up here. We don't need no HCP until the patient can't breathe, if you know what I'm saying. Central venous, that was good. Central venous or pulmonary arc cath, the pulse is not increased. Why? Because this is not a cardiac problem. This is a respiratory problem. It's kind of like the other thing we said but backwards. Now, we need to acquire some information from these patients, and while I turn the camera down, I'm just going to say some random stuff to distract myself while listening to this, so I think I'm listening to something when I'm not, but really I was just wasting time so I can get back to what they need to acquire, what health information you need to acquire for ARDS. You need to know if they're on home O2. You need to know home O2 administration. We need to know if they are on immunosuppressants. We need to know if they are on arthritis meds. We need to listen for heart sounds. And she just said this in class. I don't know if it's related, but S3 is heart failure. S4 is hypotension. High PEEP may be needed. So with that, we need to monitor that cardiac output. We're going to have increased heart contractility with dobutamine and dopamine. Call HCP. This is when we call HCP for ARDS. We call them when we have a hemoglobin less than 6. We're probably going to administer blood for that, and then O2 sat below 87 if you believe in heaven. You know what I'm saying? Now, ventilators. That's the first thing we're talking about. And the biggest thing that she said we needed to know for the exam is to prevent complications and know what to do for the alarms. So for all vents, we want to have a bag valve mask at the bedside ready to go. Just in case something goes south, we can go ahead and start getting air in. Now, aspiration is a big complication with ventilators, and risk factors for aspiration can be improper cuff inflation, patient positioning, or a tracheoesophageal fistula. Basically just stuff getting in the way of their throat. The treatment for aspiration, we're going to want to suction that oral cavity with a yonker. If they have an NG tube, we need to make sure it's on a low intermittent suction. We need to keep that head of the bed elevated 30 to 40 degrees. And if we do have an NG tube feeding, we need to check that residual. Another thing, well actually it's right here, before giving anything NG tube, we need to check the placement via aspiration and chest x-ray. So before we give anything for this patient with an NG tube, we need to do an x-ray to make sure it's in the right location and do a gastric aspiration to check the pH level and make sure it's in the right place. Now we need to turn off continuous feeding before lying them flat. So if we have that head of the bed elevated and we're feeding them, that's cool. But when we stop the feeding, we need to lay the head of the bed flat. Now we're going to go into ventilator alarms. High pressure alarms for ventilators can be related to an obstruction, the patient biting the tube, a mucus plug, and that's all what Saunders said. Now we're going into what she said in PowerPoint. A high pressure alarm can be caused by wheezing or bronchospasm, ET tube displacement, or obstruction related to water or kinks in the tubing. Now the treatment, we need to turn off the vent and bag them, and suction could be another one, just in case they have those, they have mucus in the tube or in their throat. So if it's a low pressure alarm, it could be related to a disconnection, a leak in the vents, a leak in the cuff pressure, and the patient, where the patient stops spontaneous breathing. Now on the last question, I got an exam, or on the last exam, I got a question where we had a patient that was on ventilation, and they were able to speak while on the ventilator. They're not supposed to be able to speak. If they are able to speak, that means they do not have enough pressure in the cuff. And that's the next thing we get into, is if they're talking to you while they're on the ventilator saying, "Yo, I'm thirsty, can you bring me a snack? I want some chips." That means that the nurse beforehand did not set up the alarm. So never set the alarm controls to the off position according to Simple Nursing, Saunders, and Solomon. Now let's go into neuro. In neuro, we have 5 modules. Mainly going over the assessments and head injuries and spinal cord injuries. So, neuro. For the test, we got the skull and spinal radiography. That's going to look at bones. So we could see this with a skull fracture. We could see this with any type of spine thing, like a spine injury that's a blunt spine injury or penetrating, possibly. Now, a CT scan is a lot bigger, a lot more covered. This is fluid and brain structures, so we can look at the blood in the brain, the fluid in the brain. We can see what the ICP is doing, if it's squishing part of the brain or moving parts of the brain around. That's what we use for that, CT scans. But before we do the CT scan, we need to assess for allergies to iodine or shellfish. Now, if it's a mild allergy, they might still do it, but in that case, we give them antihistamines or corticosteroids beforehand. We need to assess the renal function, so the BUN, which over 20 means bad kidney, creatinine, over 1.3, bad kidney, or urine output, under 30, kidneys aren't working, so it needs to be over 30 milliliters an hour. So if any of those signs are elevated, that could be a contraindication for a CT scan. The next thing we're going to talk about is an MRI. This looks at the tissues. It looks for tumors. It looks for vascular abnormalities. So this is basically a CT scan, but more detailed. No metal objects, so no pacemakers in this patient. The next thing we're going to talk about is a lumbar puncture. This looks at the cerebrospinal fluid, and it looks at the cerebrospinal pressure. We need to make sure the patient has the knees to the abdomen and the chin, and their chin to their chest. We're going to have to monitor the vitals. We're going to have to check that level of consciousness if they're getting confused, disoriented, if they have a headache or leaking CSF fluid. That's all things that can go wrong with a lumbar puncture. The next thing is the cerebrospinal angiography. Beforehand, we need to do the same checks that we do for everything else. We need to check that bun creatinine. And for the cerebral angiography, we need to make sure we hold metformin. We need to check pulses, and if they're bleeding, we need to hold pressure and then call the HCP. Now let's see, diagnostics. So diagnostics for neuro, we have ICP, which is intracranial pressure. It's normally 15 to 20. Over 20, we need to call the doctor. Now ICP over 20, we're going to see a change in LOC. That's the first sign and symptom that we will see with increased intracranial pressure, which is over 20. Now cerebral perfusion pressure, CPP, that is 60 to 100. Hi, I said CPP. Okay, so CPP 60 to 100, and below 50, that means ischemia, so tissue death. Now the pupils, that's another diagnostic tool used for neuro. We're going to check for that pupil dilation. Is it responsive? So when we shine that light in their eye, does the pupil constrict? If we do it in both eyes, are they equal? Are they developing ptosis? That all can mean that they have increasing intracranial pressure. The next thing we're going to talk about is Cushing's triad, which is a sign and symptom, not so much a diagnostic, but you will see it with neuro, and I didn't know where else to put it. So we have a widened pulse pressure, so a pulse pressure that's like 180 over 70 to like 190 over 60, just really, really different numbers between the systolic and the diastolic. We can see bradycardia, irregular respirations, and signs and symptoms, and these are signs and symptoms of increased ICP. So remember, Cushing's triad, widened pulse pressure, bradycardia, and irregular respirations. Now, Glasgow Coma scale is definitely going to be on the test. So basically, less than 8 we intubate. That is not good. 15 is good, unlike ICP. Well, actually, no, 15 is okay. It's 15 to 20, so it's kind of low. But the biggest thing with this Glasgow Coma scale is if you see a drop. So if they're at like a 14 and they go down to an 8, rapidly, we need to notify the healthcare provider because that can mean increased intracranial pressure, brain damage, all kinds of stuff. So here's how we score it. Motor response, and I briefed it down to what I saw in my questions. So 6 is responsive to pain for the motor response. 3 is decorticate. 2 is decerebrate, so decerebrate is worse than decorticate. And then 1 is no response. So if they have no response, how many points are we giving them? I'm asking you.
Good question.
Good question. So no response.
No response. 1.
1. What if they do respond?
6.
Cool. So now that we are responsive to pain, we're going to go with 6 for our first number. Now we're going to go into verbal response. You ask them like, what's your name?
Emily.
Okay, so 2 is the responsive, but they're saying incomplete words, and then 1 is no verbal response. So you're oriented. Apparently I'm the one that's not oriented. You're responsive to pain if I poked you. Now eye opening. Now, do your eyes open spontaneously? Yep, they're open. So that's a 4. They're spontaneous. 3 is in response to sound. So I say, yo Emily, what's up? Then your eyes open. That's a 4. 2 is in response to pain. So I poke you with a stick, then you open your eyes. And 1 is no response. So you got a 6, a 5, and a 4. 5 plus 4 is 9. 9 plus 6 is 15. You have a Glasgow Coma scale of 15. Now, nursing management for increased intracranial pressure. We're going to keep these activities under 5 minutes. We're going to avoid coughing, blowing the nose, and vagal maneuvers. No crouching tiger, no hidden dragon. We're going to do spine. We're going to space interventions. We're going to space them out. So we do one thing, we stop. Wait a while, do another thing, stop, wait a while. Now, medical management of increased ICP, we're going to make sure that they have adequate ventilation and O2 because carbon dioxide will increase intracranial pressure. We're going to give them osmotic diuretics like mannitol. And with mannitol, we need to monitor for rebound cerebral edema. Loop diuretics like furosemide may be given to lower the blood pressure, which will decrease ICP. Temperature control, that is important because if they are shivering, that means that the ICP is going up. Now, sedation, like Ativan, Valium, or benzodiazepines is really good for these patients, and propofol also can decrease intracranial pressure. Now fluids, we are giving fluids to maintain the CCP. I said CPP over there. Central perfusion pressure. It's probably the same thing. So if it's below 60, I'm going to check me on that. Now, but regardless, 100%, we give isotonic fluids to any ICP patient, increased ICP patient. And that's 0.45 to 0.95 normal saline. So we do not give hypotonic or D5W. And when we are doing fluid administration for these patients, we need to make sure that we do strict intake and output. Now we're talking about head injuries. Now the first one we're going to talk about is hematoma. We're going to see increased ICP, decreased level of consciousness, and visual changes. We may see neutral rigidity and CSF drainage. Now, with that CSF drainage, that means we cannot give them a nasogastric tube. You want to know why?
Why?
Because if we stick it in there and they have a skull fracture, it can go into their brain.
Oh no.
So, if you walk into the room and you see a patient that has a skull fracture and you have a unlicensed assisted personnel or whoever else is allowed, I can't remember right now, to do an NG tube, sticking it in there, what do? Immediately stop them, slap it out their hand and be like, no, you can't do that, you're going to stick it in their brain. And the patient's going to be scared, so don't do it like that. Now, the treatment for a hematoma is you need to assess the airway, the ventilatory status, level of consciousness, the temperature, because remember, airway, CO2 will increase intracranial pressure. The ventilation, it's good that they can breathe. Level of consciousness, if they're getting confused, then that can be a sign and symptom of increased ICP. And temperature, because temperature can also increase ICP. You see how this is all coming together now? Now, we're going to elevate the head of the bed, and that's going to decrease the venous pressure for patients with hematomas. We are going to do normothermia measures. You want to know why?
Why?
Because these patients are basically lizards. Normothermia measures? Yeah. So what that means is they're like lizards. You know, lizards go out into the sun to get warm, and if they're in the cold, they'll have colder blood. These patients could have a thermal regulation problem, so we need to make sure that we keep them within normal temperature range. So morphine and opioids can be given to decrease ICP and probably make them less freaked out that they broke their brain. Now CSF drainage, now that means no NG tube, like I said earlier. We're going to test the CSF drainage for glucose. If it's positive, we notify the HCP. So now we're going to look at cerebral aneurysm. Now we can have a headache and pain, irritability, visual changes, tinnitus, which is different. So be mindful of that, and neutral rigidity. For a cerebral aneurysm, we're going to maintain an airway, give them O2, monitor for hypertension and dysrhythmias. Now we're going down to spinal cord injuries, which is the last thing here. So spinal cord injuries, we're going straight into it. Cervical level injuries, this is in the C5, C2 range. C2, this is fatal usually. C4, we have respiratory difficulty and paralysis of the extremities. And C5 through 8, they may also have respiratory problems. So let's look at interventions for all respiratory things related to spinal cord injuries. Now it's associated with C4 injuries, as we said earlier. We need to monitor the ABGs, we need to maintain ventilation, we need to have them doing deep breathing, intensive spirometer, and monitor signs and symptoms of infection like pneumonia. So crackles, fluid in the lungs, stuff like that. But that is for all spinal cord injuries, but cervical level injuries are associated with these respiratory treatments. Now we have thoracic level injury. Let's pick a different color. You think I should go blue or green for thoracic?
Blue.
Blue. So blue, thoracic level injuries, think of the thorax. We're talking around the T6 area. This is the chest, the trunk, the legs, the bowel, the bladder, and the legs. We can have autonomic dysreflexia if it's above T6. Now, let's see here. Renal, lumbar, and sacral. That's different. Cardio. So next we're going to go into lumbar and sacral. I don't have anything for thoracic level, besides everything. But lumbar and sacral, that's going to be your lower extremities, like the In the S2 and S3, we can have a neurogenic bladder, which means they can't pee, and we need to do a Foley. And I did do renal. So with renal, we need to prevent urinary retention, so like giving them a Foley catheter. And we also need to maintain fluid status. So if they're hyponatremic, hypernatremic, hypotension, give fluids, that kind of thing. Next thing will be Brown-Séquard syndrome. This is a two-sided thing. I wish I had a brown one. And then we'll go green. Brown-Séquard syndrome is two-sided. And on the side of the injury, we are going to see decreased motor function and sensation, as well as hard touch sensation. So you've got to like punch them, they can't feel it. Then on the opposite side, we have, I would never punch a patient. On the opposite side, we have decreased pain, decreased temperature, and decreased sensation to light touch. Now for quadra equina syndrome, that is injury to the, which one can't be? Injury to the wrong color. Injury to the lumbar or sacral nerve. And with this, we're going to have areflexia of the bowel and the lower extremities. So that goes with the lumbar and sacral, and that goes with renal. Next, we're going to go into interventions for all spinal cord injuries. It looks like I could have organized this better, but I'm low on time here. We are going to maintain a patent airway. We are going to prevent head flexion, extension, and rotation. We're going to immobilize, maintain alignment, and traction. We're going to maintain an extended position. We need to do log roll. We don't want to move any individual extremity by itself. And if it's a cervical fracture, we're going to do skeletal traction. So, up here. Now we have cardiovascular. Let's do this one in red. We are going to monitor for bleeding and hemorrhage. So, increased heart rate, decreased blood pressure, just bleeding in general. It can be bleeding from the site. And shock, it's the same thing. Decreased blood pressure, increased heart rate, so on and so forth. DVT in the extremities, specifically the lower ones like the legs. So we need to measure the size of the calf. We need to give them compression stockings. And also we need to monitor for orthostatic hypertension when we are repositioning these patients. And that is all for neuro and ventilators. And that's a total of like 13 questions. Let me know.
We're rolling.
Alright, so ACLS. I did this just a little bit different because I'm not quite sure if I'm going to have time to finish all of it. So instead of doing the heart rate and telling you what you do for each heart rate, I listed out the drugs that you give and then just drew the heart rate next to it. So, and I actually found some interesting correlations. So oxygen, that is always used just about every ACLS or acute coronary life-saving, whatever. It's 100% during cardiopulmonary arrest. But here's the thing, is you don't give 100% O2 to COPDers. That's a different chapter, but I've got it just in case. Now, the first thing we're going to go over is a vasopressin and epinephrine. This is a vasoconstrictor. You got me? And the difference between epinephrine and vasopressin is you give vasopressin when epinephrine is not available. But they're both vasoconstrictors, and they restore cardiac electrical activity. That's what they do. They're used in VFib, and if you see in VFib, up, down, it's irregular. It has no definable P wave, I don't think. I mean, you just see it. You see that heart rhythm, you know that we need to give epinephrine or vasopressin. Now, VT, or pulseless ventricular tachycardia, is another heart rhythm you give epinephrine or vasopressin for. And it kind of looks like shark's teeth or, sawtooths or something like that. Now, asystole is another one you give these with, and that's just a flat line. Or pulseless electrical activity, you can give epinephrine or vasopressin. The next one is amiodarone or lidocaine. Amiodarone is preferred, and lidocaine is given when amiodarone is not available. But I think I can't be given together, I can't remember. But regardless, they decrease membrane excitability, and they're going to use a different color. Which one should I use?
Green.
Green, let's go green. We're going to decrease amiodarone and lidocaine are going to decrease membrane excitability, and they're used in reoccurring ventricular fibrillation. So ventricular fibrillation and VFib are the same. Ventricular tachycardia, which is just fast. Ventricular tachycardia is fast, but you have that same, spiky look. and then, like that too. Now, this is specifically, amiodarone and lidocaine are specifically given to reoccurring ventricular fibrillation and ventricular tachycardia that are not responsive to defibrillation or the vasopressors mentioned above with epinephrine and vasopressin. So we got VFib or VTAC, and we gave them vasopressin because epinephrine was not available. That didn't work. We are going to give them amiodarone or lidocaine. Now, also another heart rate that we can give amiodarone or lidocaine with is supra. You know about cars, right? That's yes. Right, you like cars. I just remember the Toyota Supra ventricular tachycardia. And it sounds just like a Supra whenever you punch the gas all the way down and then let off and you have that BOV going. You know what I'm talking about? It's like, so it looks, basically you have a QRS and then just the pyramid right there and then another QRS. Or really not really a definable QRS, but you have tall, skinny, short, wide, tall, skinny, short, wide. You get the idea.
Kind of looks like the Batman ears.
Kind of looks like Batman.
The first part.
Does Batman drive a Supra?
No.
Well, Batman drives a Supra today. And he takes amiodarone and lidocaine on the daily. Now, it's also... Now, for supraventricular tachycardia, amiodarone and lidocaine are used for rate control so that it slows it down. It's tachycardia. It's beating way too fast. So this is going to slow that heart rate down. Now, lidocaine and amiodarone are also used for afibrillation. Have we gone over that yet? No, we haven't. So afibrillation, it's a regular rates. Afibrillation. It's the atrial quiver. We have a risk for thrombosis with this. That's why we're not going to shock them. The P wave is not definable, and so we're going to give amiodarone or lidocaine. It's probably anticoagulants too, because they have that risk for the clot there. And A flutter, you also give amiodarone or lidocaine for, but with this one, it's a regular rate and rhythm, and instead of seeing these little squigglies, we see like waves, and we're bang. Now, the next one is going to be lidocaine. Lidocaine, let's use red or blue?
Red.
Red. Lidocaine is used when amiodarone is not available. Well, actually, it's the same thing. Why am I doing that? We'll go with it. So it's an antidysrhythmic that suppresses ventricular ectopy. And for VTAC and VFib, which we already talked about, ventricular tachycardia, ventricular fibrillation, and it can also be, and it needs to be IV pushed. So here's the correlation I was talking about earlier. You give lidocaine for the same crap you give amiodarone for, but it's used when amiodarone is not available. But here's the other thing it can be used for. It can be used for defibrillation, which is not only seen here with amiodarone and lidocaine, but it is also seen here with epinephrine and vasopressin. So, now you know that with VFib, you give them epinephrine, vasopressin, lidocaine, and you also know that amiodarone and lidocaine are swappable in any question. So the next one is going to be adenosine, so blue. Adenosine, it slows contraction through the AV node, and it's used to treat supraventricular dysrhythmias. Now, they have a short half-life, and they must be given rapidly IV push. That was a big thing in every resource I could find. The patient will have a short pause on the cardiac rhythm. So you just push the adenosine IV for a patient with a supraventricular dysrhythmia, and they go asystole, they flatline. Which the following should the nurse do? She should wait for the rhythm to resume because that is what it's supposed to do. So don't call the HCP even though he's probably already there. And it's used for paroxysmal supraventricular tachycardia, which is basically the same thing as ventricular tachycardia, but it's not supraventricular. And it can look a little bit different. You still have the Batman ears like you were talking about with VTAC, not VTAC. With supraventricular. Hey. No, we do have supraventricular tachycardia over here. We have the Batman ears, right? But we can also see it look like this. Or like this, like a McDonald's, or backwards Batman ears. And then we have the classic Batman ears. And it may also be used for supraventricular, stable ventricular tachycardia, which looks more like the sawtooth. And then we already talked about V-tach, which as well as just that. Where's V-tach? V-tach.
Go down.
Right here. Well, bam. So does that make sense? It's a little confusing, but it's like whenever, it's more about the answers here. So normally you are given the heart rhythm and you answer it with the drugs. So instead of showing the heart rhythms and then showing the drugs you give for it, I'm giving you the drugs and the heart rhythm. So atropine, right? Which color?
Green.
Green. Atropine. As you see, I changed that T to an up arrow. So whenever you see atropine, think of the up arrow. So what's it going to do? It's going to decrease the vagal tone and increase the heart rate. So that means it is used in symptomatic bradycardia only from my understanding according to the PowerPoints. And symptomatic bradycardia is under 60 beats per minute. So you see we have a QRS, a long space, and a QRS. It's going to be regular, it's probably going to have P waves, so on and so forth. Magnesium sulfate, what color?
Red.
Red. Magnesium sulfate is used in torsades de pointes. Now, this is a type of ventricular tachycardia, and it looks like this. And basically what's going on is the patient's magnesium levels are low. And it's going to make it look like this, these squigglies. And what it looks a lot like to me is some EDM music or techno music whenever they have it go through the thing. Exactly. So, and so we give them that mag sulfate. So think of mag sulfate as a DJ. Does that sound like a DJ name? DJ mag sulf?
Yeah.
All right, next we're going to talk about sodium bicarbonate. Got to use blue now. Sodium bicarbonate is used for metabolic acidosis. So we have a 7.35, 7.45 is pH, so it's going to be below 7.35. The PaCO2 should be normal or compensated, but the thing we need to worry about is that bicarb. So the bicarb in acidosis, it's below 22. So if we have a patient that has a crazy heart rhythm, we've already done everything because this is primarily used is rarely used and given in desperation. We may give them sodium bicarbonate to fix the metabolic acidosis. Now, a big thing with sodium bicarbonate is we do not want to mix this with other drugs because it will crystallize. So we need to make sure that the line is clear. The last drug I'm going to talk about is dopamine. And we go back to green because it's all circling around because I didn't read all of them before I started writing. So dopamine is given for symptomatic hypotension, or really low blood pressure. So blood pressure that's like 80/60 or something. Now, it is symptomatic hypotension with the absence of hypovolemia. So basically, it's given for decreased blood pressure with normal fluid volume. And it's also the second line med for symptomatic bradycardia up here. That's another med. So for symptomatic bradycardia, we give them atropine or dopamine. And another thing with that dopamine is it's given for low blood pressure when there's a normal fluid volume. But if we have a fluid volume deficit, don't give them dopamine, give them fluids. And that is the basis of ACLS. All right, so now we're going over heart rhythms as you normally would. So the first one we're going to look at is sinus bradycardia, and that is when the heart rate is below 60 beats per minute. There is no treatment unless symptomatic. So we're going to find the cause, call the healthcare provider, and give O2. So that's sinus bradycardia. We could be giving them atropine or dopamine to increase the heart rate, and we're probably going to give them a pacemaker. So as you can see, it's just like regular, but it's slow, very slow. Go over sinus tachycardia, the opposite of sinus bradycardia. And with sinus tachycardia, we have an increased heart rate, 100 to 180 beats per minute. We need to find the cause and treat the cause. So think about it. if they are having increased heart rate, like rapid heart rate, 100 to 180 beats per minute, if they're drinking a lot of caffeine, stop drinking caffeine. If they're doing cocaine, stop doing cocaine, so on and so forth. We may give them beta blockers, calcium channel blockers, and lifestyle changes, like don't do cocaine. Fibrillation was the most covered in the textbook, in class, and everywhere else, so I got the most information for it. So basically atrial fibrillation. Then we got atrial quivers with atrial fibrillation. And we have a risk for a thrombosis or blood clots. According to my PowerPoints, the heart rate, not the respiratory rate, or the rhythm or whatever, the rate's 300 to 600, but according to simple nursing, it's over 100 beats per minute. The P wave is going to be absent or not definable, so no P wave, and there is going to be no pulse rhythm, or PR, and we're going to have a QRS that is normally irregular. So the treatment is going to be O2 and anticoagulants. The main treatment for this rhythm right here. As you can see, it goes up now, we'll big. Like we got all those little waves in the middle. So it's stable atrial fibrillation. We're going to do beta blockers like metoprolol and the digoxin. And for stable atrial fibrillation, you could also give anticoagulants or calcium channel blockers like dialtazam, but we need to worry about fluid volume overload with dialtazam. And we're going to do the echocardiogram. We're going to get that for this patient, and we're going to check the BNP. That's probably the first things you're going to do. Now, if it's unstable, we're going to cardiovert. Surgical therapy is cardiac ablation. Signs and symptoms of atrial fibrillation, which is the same almost everything on here. It's chest pain, decreased O2, decreased blood pressure, lethargy, anxiety, palpitation, short breath, and dizziness. Next, we have atrial flutter, which is very similar to AFib, except we have a regular rate. And we're going to have 3 sawtooths for every QRS. That's how you know it's atrial flutter. So as you see, 1, 2, 3. That's 3 sawtooths. And then we have a QRS. 1, 2, 3 sawtooths, and a QRS. So the treatments, if it is stable, is going to be surgery, like cardiac ablation. We're going to give them anticoagulants, beta blockers, the digoxin. And if it's unstable, we're going to push that adenosine. PVC. Now the PVC, as you see, we got this, regular heart rate, and we'll bang. It's normal, but it's bad if it happens too often. It's normally, if it's every other beat, it's bigemity, and if it's every third beat, trigemity. No main TX as mentioned by the PowerPoint notes. We have a premature atrial contraction. That is characterized by this bad boy. We have normal QRS, and then we'll bam, we skip to the next beat. It can be caused by drugs like smoking and alcohol and caffeine, so we need to do lifestyle changes. We may give a calcium channel blocker like dialtazam. Paroxysmal supraventricular tachycardia. And you can see it here. It's episodes of increased heart rate up to 120 and 130 minutes, but it starts and stops suddenly. We need to assess for drug use, caffeine use, all that kind of stuff. If it's stable, least invasive first move to the vagal maneuver, cough and bear down, maybe push adenosine. But if that'd be for unstable. If it's unstable, we're going to synchronize cardiovert and push adenosine. Probably push adenosine first, then synchronize cardiovert. Yeah. So we have VTAC. We have sustained and non-sustained. So sustained, we have supraventricular, or we just have VTAC going up and down all the way, right? So first bring them to cough and bear down. If that doesn't work, we're going to call a rapid response team and be ready to cardiovert. But this rhythm can lead to VFib, so we want to shock early. For non-sustained, it's kind of like paroxysmal supraventricular tachycardia. It's normal, but then we have this VTAC, and then it's normal again. If it's stable, we do the vagal and amiodarone, which is probably the drug for stable for paroxysmal supraventricular tachycardia. But if it's unstable, we have no pulse, we defib. Next, we have ventricular fibrillation. That means the heart quivers and doesn't pump. No organized rhythms, no organized contraction. If there's no pulse, or any of the, with VFib, we defib. So VFib, look at it. It just looks crazy. It's like a Picasso painting. Last is asystole. And that is, we need to check the leads and call a code. We may give epi, or no, we're going to do a CPR. We're going to check the leads, call the codes, epinephrine, CPR, and ET tube, and maybe give epinephrine and vasopressin. As you see, we do not defib this patient. It's a flat line, assist the lead.